Welcome to the Innovation Accelerator podcast, brought to you by Innovacer, the health cloud company. We're on a mission to connect and curate the world's healthcare information to make it accessible and useful. With Innovacer, everyone works in the service of patients like never before as one. Visit us online at innovacer.com.
Welcome back to the Innovation Accelerator podcast. I'm your host, Steve Ambrose. And on today's show, our Chief Innovation Officer, Dr. Anil Jain, will have a forward-thinking and highly engaging conversation on healthcare transformation with Dr. Alan Weiss. Dr. Weiss is the Chief Medical Information Officer of BayCare Health System, and he's responsible for all clinical systems at BayCare, their associated governance, as well as providing executive leadership over data and analytics. His prior efforts included CMIO and EHR related experience at Memorial Hermann System in Houston and Cedars-Sinai in Los Angeles. Dr. Weiss is passionate about patient care and the proper use of data and analytics to refine EHR development with a heavy emphasis into the inclusion of evidence-based medicine. And we're happy to have him on the show. I'll now hand it off to host Dr. Anil Jain.
Well, thank you, Steve. Well, Dr. Weiss, maybe I should call you Alan since I've known you for so long. Thanks for coming on the show and sharing time from your busy schedule. I can only imagine what you and your colleagues are going through during this time. Now, I've been looking forward to this conversation and getting your thoughts on a number of areas specific to digital transformation. But before we do that, can you please share a little bit about your current role and company, as well as your background that led you to this role? And if you don't mind, tell us a little bit about your recent Changemaker award.
Thanks, Anil. And Anil and I worked together 20 years ago at the Cleveland Clinic, and we're clinical partners for about 10 years before I embarked on an informatics journey. So we know each other really, really well. So my background's a little bit unique. So is Anil's. I actually have a computer science and philosophy degree from the University of Michigan as an undergrad. And from there, I ended up in the pharmaceutical industry, helping to create databases and analyze them for the FDA and for medical journals. It got me really interested in medicine. I didn't really know how to pivot and ended up starting my MBA, realizing it wasn't for me, taking time off to do pre-meds, and then ending up finishing my MBA, going to medical school, becoming a general internist, and ending up at the Cleveland Clinic. And at the Cleveland Clinic, as Anil knows very well, they had just put in their first EHR, their only EHR, and I quickly, because of my computer background, helped them to develop the system, implement it, and optimize it. And it really, for me, was a combination of my backgrounds, the business background, the computer science, and frankly, the medical background and being an internist. So I really enjoyed that work. And after that, I embarked on a clinical career, an informatics career that has taken me around the country. And I've been at my role here at the BayCare Health System for about 4 years. BayCare is the largest healthcare provider in the Tampa Bay region. We have something like 15 hospitals, 200 some odd clinics. We do roughly 160 to 170,000 admissions per year with over 2 million ambulatory visits and somewhere in the range of about 600 to 700,000 ED visits per year. So we do an awful lot of work. We're a $4 to $5 billion company, and it's we're non-for-profit. The thing that I really like about the organization that I'm with is that they really focus on quality. They like to say quality is their true north. Everything that we do is about how we improve the patient care, how we improve the services for the patients and their families. And for us, I think we're really dedicated to that mission. I really appreciate that vision and that mission. In terms of the Changemaker Award, because I know you're going to ask again, I was honored this past year to get the HIMSS Changemaker Award. It was an award that was voted on by colleagues across the country, actually across the world, and really was a reflection, I think, of some of the work that I've done in informatics for the past 20 years, of trying to refine the EHRs, use the data within it to help improve quality, address operational concerns, help out with efficiencies. And I was very honored and humbled to have received that award.
You know, when I think about the clinician's role or the physician's role in all this digital transformation that's happening, and some of the challenges that you and I both saw in the early days of EHR implementations, give me a sense of, and we know that digital transformation is happening across organizations at various different levels. across different needs. How do you see clinicians resonating with the digital transformation efforts that folks like yourself and your peers are engaging in across health systems? What lessons have you seen from that?
So I would tell you from a clinician point of view, it's a bit of a mixed bag. It's not as positive and as people would like it to be. And the reason I say that is, when you think about digital transformation, you think about creating the tools, the workflows, and the efficiencies that allow the consumer to come into your system through some kind of digital means and stay engaged in a digitally efficient or appropriate manner. For patients, it's the use of various types of portals. It's getting data in. It's conversing with the physicians on a regular basis. It's easier means of both doing emailing, contact, and in some way engaging with the healthcare providers. And so to me, the patients really want this, and they embrace it probably more than the clinicians. And I say that because from a clinician point of view, there are problems and work that's added on to their overall, frankly, overburdened schedule to try and handle all of these issues. And what I mean by that is, let's say a patient emails you. Where do you have time in your schedule to handle those emails? If they send you the data, either on glucose or blood pressures, how do you respond? How do you have time to actually look through and handle those issues? So for the physicians, it's a mixed bag. And I think it's great that patients can engage you and that the system wants them engaged, but I'm not sure that the physicians have been given time to respond in an appropriate manner.
Well, Alan, you gave a great example of where clinicians might be pushing back, and which is basically responding to the flood of emails, and I'm sure they're getting inundated, where patients may want to communicate with their clinicians in a fundamentally different way, at their own time, at their own leisure. What are some other examples where clinicians are pushing back on the way that the healthcare workflow is being digitally transformed?
So I would tell you, Anil, that there are additional regulatory, population health, additional needs that the providers have to handle inside of the patient workflow. We're asking more questions to handle social determinants of health, social issues. All of those add a burden onto the provider. And the struggle within that is that as you collect that data, the provider has to do more, both to get the data in and to do something with it. All of that lends itself to a greater amount of work that the providers have to do day to day and on each patient. That's a struggle overall. And the workflow hasn't been quite refined. Everybody talks about population health nowadays, and population health and digital transformation, they're similar in some ways. They do go hand in hand. The analytics go hand in hand with the digital transformation, and some of the tools go together in a digital transformation kind of way. But population health, the ability to care for an entire group of patients, requires a team. Right now, I'm not certain that we have that team identified for a lot of providers. And as a result, many providers, particularly I would say in primary care, are feeling more overly burdened than before.
Yeah, that's a great point. And you're bringing up issues around change management, which I hope we have. We'll get to some of those issues in a moment. But we both have watched the electronic health record be implemented, and wasn't it supposed to sort of solve some of these challenges? Where do you see the role of the electronic health record when it comes to the digital transformation and addressing some of those concerns that you just outlined?
So yeah, you and I have been dealing with the electronic health record since its inception about 20 or more years ago nowadays. I look at that and I think the EHR has both solved and created problems. Like, no one liked the paper chart. It was messy. It was hard to read the handwriting. If somebody took the chart away from your patients, you couldn't find it. There were all kinds of issues with the paper record. And those were solved largely with the electronic health record. But there are things that are much more inefficient inside of the EHR. And those inefficiencies have yet to be solved. In addition, I would tell you that in the process of handling all of the regulations for EHRs and about EHRs, we weren't exactly making the EHR more efficient. So there are workflows you've got to go back and rethink. I would also tell you that as I start to think about the data that we collect a lot of data because somebody thought it was a good idea. And in asking about that piece of data, it adds the amount of time that people spend in the EHR. And it doesn't exactly lend itself to some kind of clinical usefulness. I'll give you an example that we've dealt with here at Baycare. Something very simple, like collecting a family history on a patient. When we started to look at the family history section inside our EHR, we had 140 some odd items in there that our nurses and MAs and physicians were asking about. Some of the things, when you started to ask them, didn't make a lot of clinical sense. For instance, we asked about whether a patient had a family history of sore throats. Well, everybody has a family history of sore throats. We asked about a family history of, I think we asked strep throat. We asked whether or not people had a family history of earwax. All right, well, whose family doesn't have a history of earwax? Clinically, when you start to think about family history, the clinical usefulness of it is in either helping you diagnose or in some way prevent a disease. So if I've got a family history of early heart disease, I may want to do some additional tests earlier on. When it comes to something like a rheumatic disease, because they can present in very unique ways, having a family history of rheumatic diseases can help you in diagnosing patient care. But we collected 140 some odd items. Most of those just weren't very useful. We cut it down to about 35 after a lot of wrangling with a lot of specialists. We have to go back to the EHR and make it more efficient. And in order to do so, we have to rethink the clinical usefulness of it. Part of that, as I said, is the data you put in. Part of that is also legislating common sense through the electronic health record. For instance, when it comes to nursing care, does a nurse need to be reminded that a patient needs to, have oral care every day, or that they need to follow procedures, or that the vital signs are as per whatever unit they're on? All of that clogs up the EHR with more data, more information, more scrolling, and the result is a lot of cognitive fatigue within the electronic health record that actually detracts from the care that you want to provide. So we haven't made people more efficient necessarily inside of the electronic health record. And in some ways, because of that cognitive burden of trying to assemble all the data in different places, we've actually made it more difficult.
Yeah, that's a great point. And especially when we are all resource strapped, I think it's even more important to really focus on what is really necessary versus just busy work. And maybe it's time to revisit the checklists that, in the earlier phase of building these things into electronic health records. What are the most critical pieces? And kudos to you guys to having sort of dealt with that head on with the family history. What are some other large transformational initiatives that you feel that we have to do it in order to make the electronic health record more useful?
So when I start to think about the work that we are doing now, it's trying to do analytics behind the scenes to understand what is evidence-based medicine, how are people really using the evidence, and then somehow embedding that into the day-to-day workflow of the providers. So we do that. We have these whole care pathway kind of project that tries to get patients with congestive heart failure or hip replacements onto a pathway, make sure they do everything according to the book, everything according to evidence, and then streamline the process of providing the care all the way throughout their hospitalization. So we do that kind of work right now, and that's really fascinating work. But that's great. That's sort of leading somebody down the right pathway, making sure they do the right things. The hard part is, what if you do the wrong things? Do you need an alert in there? Do you need some other process in there? That's where things get a little bit funky inside of the EHR. And funky, by the way, is a technical term for what we put into the system. It's really, how do you get providers who do things outside of the norms and get them back onto a better pathway, a better decision making? And we're working on that, and it's difficult work. I'll give you an example from the analytics approach that we've taken at Baycare. And the example that I have is less about the EHR and more about decision making. Now, you and I, Anil, have put in plenty of alerts. We've done a lot of work on clinical decision support. And the essence of clinical decision support is really about trying to get a provider to do something different. That's really what it's about. Whether it's something acute like a med allergy or a decision about patient, that's what CDS is all about. So at Baycare, like many organizations, we struggle with the controlled substance epidemic. Everyone across the country has. That epidemic has unfortunately taken the lives of more than 1 million Americans over the past 20 years. It's a horrible situation. What we have done is we've created an analytics approach that allows us to find the providers who are, let's just say, they're looser in their prescribing habits. These are those outlying providers who give controlled substances to their patients more often than their peers. And by peers, I mean same specialty, right? Because internal medicine is different than pediatrics. We have an analytics approach where we can find any kind of provider, any kind of specialty, any kind of unit, and even a clinic, and look at that area and take that analytics and find those providers who are somehow prescribing more than their colleagues. What we have found is by just sharing the fact that they're an outlier, those providers who see themselves in relationship to their peers change their behavior. So we can show this kind of information to them. And when we study it a year later without any kind of alert, without any kind of follow-up, we find that the vast majority of them take their prescribing habits and return it to a normal level. That's the kind of thing that we have to begin to think about in terms of the work that we do around the EHR, not just within the EHR itself.
Yeah. And certainly that's our philosophy as well. It's all about behavior of the clinicians, behavior of the patients, behavior of all the different folks in the ecosystem. And you brought up something really important, which is that data and analytics are key to understanding where we are if we're going to make any changes. You sort of described how we can reduce clinical variation, or at least thinking about how we approach reducing clinical variation. When you think about where health systems are actually making investments, they've sunk a lot of money into electronic health records. As a country, taxpayers have funded $36 billion of bringing electronic health records into hospitals. When you think about some of those initiatives that you just mentioned, reducing clinical variation, changing clinician behavior, using data and analytics to really dig into the data and giving people visibility into their own behaviors, where do you think health systems are ready to make investments to be able to sort of support those types of activities at scale?
I would tell you where I think we're going to invest, and where I think many of the colleagues that I'm interacting with on a regular basis are starting to focus their energies. Some of that is on the efficiency of providers within the electronic health record. I would tell you I see more digital voice aspect of this, natural language processing. I see more dictation using systems that pull out key pieces of information to help automatically fill in some of the quality measures that some of the providers have to deal with from a regulatory point of view. I see more of that kind of work going on a regular basis. In a similar way, I see more voice being used by the patients in patient portals, in telephones, that sort of automation that allows the patient to engage in a, well, frankly, more friendly kind of manner. So I see a lot of work being done in that manner. I see probably more work being done in population health measures that extend some of the work both to a patient before they hit a hospital, while they're in the hospital, and then post-operatively as well when they get home. So for instance, when it comes to our hip replacement patients, we're trying to see how we can get these patients tuned up before they have their operations, while they're in the hospital, and then afterwards. And that tune-up can be stuff like getting diabetes under better control, helping them with physical therapy before they get in the hospital, while they're in the hospital. It can also be stuff like blood pressure control and quitting smoking. All of these things mean fewer infections, better control post-operatively, fewer readmissions, less complications. So I see us extending some of the tools that we've used in population health to a more proactive and approach, both, as I said, before a patient's hospitalized and afterwards. I see that kind of investment going on. The other aspect that we debate, and it goes back and forth, is the entire issue of artificial intelligence and the data analytics around it. I think this issue is fascinating, and one that you and I could debate and talk about for quite some time. You have just a little background in this. I would tell you that we're probably heading down the pathway where there will be what I would say are focused artificial intelligence tools to help providers at certain key aspects of care. For instance, we right now are investing in a radiology artificial intelligence program to help us understand if a patient could potentially have strokes. If by doing that and see if the patient potentially has a stroke, we can do an intervention earlier. And frankly, as our neurologists like to say, time is brain. So when you have a stroke, if there's a way to do an intervention earlier, it can both prevent some of the morbidity issues in there as well as improve mortality. So I see a lot of investments in those areas.
Alan, that's a perfect segue into a question around cost. You talked a little bit about reducing clinical variation. You talked about reducing readmissions, having better outcomes, avoiding complications. That's all to get at reducing unnecessary cost. And it's certainly an area of focus that many of our clients tell us about, and certainly an area that we are embarking on. So, according to a recent Strata and HFMA poll, nearly 89% of healthcare organizations have some type of cost reduction program in place. But, and perhaps this might be not a surprise at all to you, but only 6% say their program is extremely effective. So, as reducing cost is one of the biggest initiatives in the quadruple aim, how have you seen some of the digital transformation efforts helping reduce unnecessary healthcare cost?
We, too, have a cost reduction effort and an efficiency effort that has been going on now for about past 6 or 7 years, and has really kicked up. The costs that have increased as part of the pandemic, whether it's additional testing, there's a whole notion of the cost of staffing, particularly around nursing, and there's supply costs. All of those have risen, and really they've hit the bottom line of our organization, and I think most healthcare organizations are suffering along those same lines. So kicking up those efforts to try and reduce costs are extremely important. We have several efforts on those on that front that I'll tell you about. We do have this care transformation project that oversees all of them. One thing that we work on is these care pathways, which is really trying to lead a patient through an evidence-based pathway when they're in the hospital. We have a care progression arm of that, which looks at trying to lower length of stay, whether that is reducing some additional testing, getting rid of consults that aren't needed. It's also trying to do care transformation rounds so that everybody is aligned with whatever is a barrier to a patient being discharged. All of that falls under the care progression. The last one is a care transformation, or rather a clinical services utilization arm that looks at excess testing. The example we have from excess testing is stuff like a hemoglobin A1C is used to help monitor diabetes. You need it, depending on who you are, probably every 2 to 3 months, maybe 4 months, depending on how well controlled your diabetes is. Certainly getting it every day in the hospital is not a very useful kind of marker. It doesn't change that quickly. It shouldn't change that quickly. So that's not useful. Part of our work is, once again, get the patient on the pathway, remove any of the barriers to discharge, and then get rid of the excess. The getting rid of excess arm has somewhere for us yielded about $23 million per year of excess that we've removed. Some of that is lab testing, some of that is radiology testing, some of that is on trying to standardize all of the pharmaceuticals across the hospitals. So we've done that in different ways. And care transformation, frankly, becomes an entire arm of what we do inside the EHR. Whether it's an alert that tells a provider that they don't need something, whether it is a tool to see where a patient is on the pathway itself, all of this is part of the digital transformation and digital efforts that we've done in our organization. And these efforts are going to continue for quite some time. Now, I'll tell you the whole notion of why that 6%, why aren't we successful? Well, I'll tell you, first of all, that the race has gotten more difficult. We've taken care of a lot of the easy stuff out there. The A1Cs every day. We can take care of that. It's now trying to figure out what those additional pieces of cost that are there, and how do we possibly approach it through some kind of analytics, some kind of intervention. And you and I have had this discussion in the past, and I'm sure you'll remember it. You look at what happens in a hospital, in a clinic, it's sort of like a gigantic, three-dimensional, very complicated game of Tetris. There's a whole bunch of stuff that needs to fall into place. You're trying to adjust all the pieces to somehow get an answer. We just don't know what size those pieces are, how fast they're coming down, and where to have those interventions. And for us, it's a huge challenge. Probably spend, several hours and several meetings each week just trying to figure out where we need to put our focus, where we have to do our next intervention. And we debate whether or not those interventions are actually going to have the kind of effect that we want them to have. And we'll keep going at it. And I think it's a fascinating way of both using an operational approach, a clinical approach, and a financial approach to a lot of these issues. I love these challenges, but they're not easy to fix.
No, that's a great point. And I love your 3D Tetris example. But if you start to take that example and you start to apply it to the quadruple aim and thinking of it as a 4D problem in which you may move one lever and then have the other levers be impacted. And for the audience, the other three parts of the quadruple aim, in addition to cost, are improving population health, the patient experience, and the clinical team's well-being, which is front and center these days. When you think about your clinical transformation efforts, what specific results have you been able to obtain on the other parts of the quadruple aim? How have you been able to move the other dimensions, if you will?
I will tell you that when you look at some of the work that we've done around patient experience, let's deal with patient experience right now, we have seen a lot of the scores on patient experience go up over the time, whether it's a star rating, whether it's some kind of HCAP score. We've seen those go up. Some of that is due to digital, and frankly, some of this is just due to common sense. It's trying to make sure that providers sit down with patients and spend time and listen to them. That to me is just common sense kinds of approaches, but we have enabled some digital aspects of this. I'll explain. So we have enabled inside or put into every single room an Echo Dot, and we use Amazon. Mm-hmm. And the patients now can use it to do simple things like make a phone call, put music on, but they can also do stuff like they can call a nurse. And they can call a nurse and do stuff like, let's say they ask for ice chips. Now, getting ice chips is certainly something that a patient wants, but it's not necessarily something that a nurse needs to do. So we take that call, and by using some of our digital tools, we send that to a tech. We send that to an orderly. We send that to somebody else other than the nurse. If a patient says, look, I'm in pain and I want my medications, that goes to the nurse. And the way we set this up, if that nurse, the nurse that's part of that care team, is off taking care of another patient, we have an automatic escalation so that it goes to a different nurse so that somebody can cover. That has led to an improvement in our patient's approach or a patient's feeling towards our healthcare system. They like this. The patient's family likes it as well. It seems simple, but it has led to patients enjoying the experience of being in the hospital better. In a similar way, we've made it easier for patients to order their food. You can do it through the Amazon Echo. You can also do it through the TV. We've made that process easier and more satisfying. And so some of these digital tools have just helped the patient. I would tell you that we've also, as part of our efforts, we've taken data that we normally would hold back from the patient and made it available inside of their patient portal. So they can view their labs, they can see the physician notes. That has engaged the patients in their care. And since it also is often shared with their family, that engages the family. So that has really helped the patients. And I think that's going to continue for quite some time. And we'll see what other ways we can improve that patient experience.
Well, that's a great example. And I wonder how long it's going to be before that becomes a sort of a standard of care where patients should be able to use some sort of ambient technology to get basic information about what's happening in the hospital. So you talked about the consumer side and you talked a little bit about the clinical side. Often what we hear from our clients is that there are silos of data scattered throughout the organization. And sometimes, like what you guys are doing with your Amazon Echo project, it means bringing together different types of data together in order to go solve a problem. how do you see a robust data and analytics, sort of a single platform view as a way to be able to analyze the data and bring what has traditionally operated in silos, and thinking about digital transformation as a way to bring different disparate groups within your health system and among your peer health systems together to go create some new value in order to hit that quadruple aim?
Yeah, siloed data in healthcare systems is a big problem and a big challenge. I would tell you that even at Baycare, there's been some siloing between our clinical outcomes group and our enterprise data warehouse group. They function with different leadership. They do similar work, but not necessarily the same work. That's been an internal struggle that we have been dealing with. To break down that barrier, we are spending more time inviting both teams to work together. And we have an overall data governance that invites people from both areas together to try and understand what we're doing on certain clinical, operational, and financial issues, and how we use both areas for the right approach. And to me, that's breaking down the entire group's thought that one piece of data needs to remain within their purview as opposed to global. Probably the biggest asset that the healthcare organizations have is data. When you take away the people and the patients, we have so much data. We're still just trying to understand how to use that data, though. How do we use it to improve the operations? How do we use it to deal with the quadruple aim? All of that becomes a big challenge within our organization. I think we're getting better about it, but it's still a struggle.
Alan, that's a great point. I think that data readiness, to make that data ready for actionability, is a really important piece of all this. And different groups are approaching it in different ways. We don't want to repeat the failures, if you will, of the large enterprise data warehousing projects of before. How are you thinking through how this is going to be a different story than the EDW challenges of the past?
So I would tell you that one of the things that we're doing is trying to enable better tools within our enterprise data warehouse so that they have better ways of analyzing the data and moving to platforms that allow you to analyze it faster. Mm-hmm. We're also uniting our approach. When I started like 4 years ago, we had different ways of defining length of stay. Was it a midnight rule? Was it an actual time rule? We went back and forth. And there was, as I mentioned, a very little on the data governance side to help us. So we had 23 length of stay dashboards. Almost none of them were being used, but somehow they'd been developed. We have a more united approach now. We have clinical leaders who are taking ownership of those various clinical areas. And we meet regularly to understand both where our clinical outcomes and enterprise data warehouse can help in that regard. And so it's a more coordinated approach. We're trying to avoid redundancies, retire anything that is out there and hasn't been used, and make sure that we have a very clean definition on what we're using and how we're approaching issues. It's challenging, though. One of the big challenges that we have is dirty data. And there's a lot of dirty data out there. I had a meeting with a vendor a few weeks back who said that they're estimating that EHR data is roughly 20 to 30% dirty in certain areas. And that's really interesting. And with the calls for interoperability, how do we absorb more data into our system when a lot of that is dirty and isn't clinically useful? And that's become a challenge for us. We're still trying to work out the details with that because we really want the data to come in, but we want it to be something that isn't redundant and is accurate. We're not quite certain how we're going to do that.
Yeah, that trust and transparency is going to be really critical. As you see interoperability taking off and folks are going to be bringing data from all sorts of different providers and health systems into your system, how do you trust it? And how do you define what is dirty and what is not? I'm a little bit surprised. I would think that EHR data might even be more dirty than the number that you were told, just depending on what you look at. Other than the data dirtiness, which I would agree, and I would think is much higher than that, but also the interoperability that we are all promoting in the industry is very much a technical interoperability less so than a semantic interoperability. What gaps do you think we will still have once we have a longitudinal patient record that brings all the data together? And what opportunities will we have?
Wow. Not a great question. Great series of questions, right? Let me first deal with the data dirtiness issue, because I think it's worth us discussing a little bit more in detail. I'll kind of hedge my way over to a better
Sure.
answer, right? So I'll tell you that one of the things that happened when we first started implementing our population health tools at Memorial Hermann was that we found a lot of problems with data. And the problems were with something simple like identifying diabetics. There was a time, as you and I will both remember, where to become or to be diagnosed as a diabetic, you needed to have a fasting glucose or a glucose tolerance test. And there was some discussion in the works about using the hemoglobin A1C as a potential screening. And there was a lot of debate in the literature. As this debate happened, there were some providers who used the hemoglobin A1C for screening and some who used the fasting blood sugar. But insurance companies often wouldn't pay for it. They won't pay for a hemoglobin A1C unless you're a diabetic. So at Memorial Hermann, when we implemented our population health platform, we found that we had 20,000 diabetics who never had a hemoglobin A1C that was abnormal and had never been on any diabetic medication. And that's because their providers had used a hemoglobin A1C, and to justify getting it done, they'd put in the diagnosis of diabetes. So we had 20,000 diabetics out there. To help out with that and help out with data cleanliness, what we ended up doing was introducing a concept that we called a stale diagnosis. It was basically a diagnosis that had been used maybe once somewhere in the past, but there had been no clinical evidence to support it, and there had been no interventions since that time frame. So, for instance, angina, chest pain. You and I have had lots of patients who get admitted for chest pain. That's not necessarily angina from a cardiovascular point of view, but it gets coded as angina. And a lot of patients end up with angina as a problem on their problem list, and that persists over time. That throws a whole bunch of dirt into the EHRs. As a result of that, we did introduce this whole stale diagnosis, and by changing our population health tools and our analytics behind them, we refined it. Now, the way I think about this is, it's sort of like you and I use our credit cards all the time. If you do a purchase that's outside the norm, you get a call. Whether you did it in a different country or you bought something at a higher amount, you'll get a call. We need to make our EHRs and the analytics behind the scene as accurate as those credit cards so that we can very much trust the data that's coming in. That, to me, becomes an essential part and an essential challenge as we move forward. Once again, stale diagnoses, data from certain offices that are bad. And I'll handle the office issue for a minute, and I'll tell you another story. When I was at Memorial Hermann, we had an outbreak of measles. And it was bad. It was something like 800 patients had measles. And the problem is that it was measles inside the EHR only. In one of our offices, one of our providers, as opposed to using a vaccine for measles, used measles as a diagnosis. And then ended up on the problem list. So 800 patients had measles. None of them actually had measles. Well, that throws a whole wrench into the data that you have. We see that all the way throughout our data that we get from all of the systems. We need to figure out which offices are bad, which providers do the wrong thing inside the EHR, give the wrong diagnosis. We need to refine our data and analytics so that we can figure out where the data is that we can trust and bring that in. To me, that's one of the major aspects of digital transformation. It's trust in what's actually inside the system. Now, you mentioned the whole notion of the longitudinal patient record. One of the biggest challenges that the EHRs have right now is telling the longitudinal patient story. At what point did a patient become obese, develop hypertension, develop obesity, develop complications associated with obesity? All of those things become something you have to dig into the EHR and figure out. It's hard to understand how the meds changed over time. who originally prescribed them, how the dose changed. Those things make it more difficult for us to provide care as providers. What I think is going to happen over time is that the EHRs, as you bring all the data in, I see more visualization tools, more timeline views that will allow us to tell that patient's story in a much easier way and stop the chart diving that we currently do inside of the EHR. That's something that I'm hoping to see in the next couple of years.
No, that's a great point, Alan. And I think what I'm hearing from you, it resonates with our patient 360 approach as well, is that you want a set of data that's been triangulated to be as accurate as possible with as much evidence as possible. And certainly before exposing that to a patient, you want to make sure that it's been vetted. You don't want the patients to be seeing on their patient portal that somehow someone has diagnosed them with diabetes when they were simply ordering a test, or worse, measles, or have the CDC automatically get a set of data about measles because of the way that the interfaces work. That's a really, really important point. How do you think about the longitudinal patient record with the fragmentation that happens in healthcare? As great as Baycare is, my assumption is that not every patient gets all of their care at your organization. So how do you feel about the longitudinal patient record, being more longitudinal?
So it's a great point, and certainly interoperability will help to bring the data in from the other organizations that the patients go to. We struggle in that regard. Tampa, in many ways, is a city of snowbirds. So a good part of that population comes down to Florida in the winter. You see a lot of Canadians, a lot of people from the Midwest. People come from all over to enjoy the time that they have here. And of course, if you're elderly and you've got medical problems, there's a likelihood that you could be hospitalized, and we've got to go find the record from all over the place. That has its challenges. And I think the interoperability will help us. But once again, how do you bring it in and make it useful? A lot of the data that we get from an interoperability point of view, frankly, it's often faxed documents that get sent over, or it's buried in the electronic documents, and it's hard to figure out what exactly is going on with the patient. I do think that if we can move into a similar longitudinal view of the patient record, and we could combine those over time, I have a feeling that we could combine and create a better view of what has happened to the patient in the past, and then agree to what needs to happen in the future for that patient care.
Yeah, that makes a lot of sense. So, Alan, with so much focus on health equity and much of what we would consider support services, social services, food banks, and so on, a lot of the data that tells us about our patients is not the traditional clinical data that moves back and forth through some of the interoperability mandates. Do you see that as a gap in our current view of longitudinal patient records? And what other types of data would you want to see in the LPR, if you will?
Yeah, sure. Let me handle the social determinants of health issue right now, because we have been debating this for quite some time. I will tell you that Baycare is a mission-driven organization. I mentioned before that they are very focused on improving the quality of the care they provide, but they're very community-driven. They really try to do the best from a community point of view to address health equities, and that becomes very tough. We try to figure out, as we collect the data, where our interventions lie. We have an entire food bank approach on the inpatient side, tries to screen patients for food insecurities and get them hooked up with community resources. We're trying to address other types of health equities now. The hard part becomes, where do you gather that data? When do you gather that data? And what do you do with it? Our providers are really struggling in that regard. I'm a primary care physician. I still practice. When a patient comes in with a health equity, how do I collect that data, and what resources do I have to address it right then and there? We haven't quite figured that out. We haven't figured out, for instance, that if a patient has transportation problems and I'm at the clinic, where do I send an order to help get that patient either to come to my clinic or to get home? All of those things are details that we're still working out. We're still thinking about the entire housing issue and what we can do with housing. This whole notion of food deserts is another one that we still deal with. And food as medicine becomes another one. And that relates to both your food insecurity, but also relates to diet. Diet certainly underlies a lot of the healthcare problems we have in the United States. So we're struggling on that social determinants issue. So I'm not certain that we have quite worked it out. You asked about other types of data, and people talk about the kinds of data that they want to see in the EHR all the time. For instance, I'm wearing my Apple Watch, and the Apple Watch has an ability to capture an EKG. It can tell you whether or not I'm developing an arrhythmia. That's great. We can use our Apple Health app to collect data from other EHRs, whether it's blood pressure data. It can be all kinds of additional problems. We can bring that inside the EHR. But our providers struggle with what to do with that data and what their responsibility is. For instance, right now with the Apple Watch, if there's an arrhythmia, the only way that I can detect if there's an arrhythmia is to go into each individual patient's chart and look up their arrhythmia and the Apple Watch data and see if there's an arrhythmia on that rhythm strip. I don't have an alert right now. I can't go and say I've got 2,000 patients, which of them have Apple Watches, which of them are sending us our data, and these are the patients that I need to worry about from an arrhythmia point of view. There's no roll-up. And at a time when the providers are feeling overwhelmed, getting that data inside of the electronic health record just seems overwhelming. So I think we have a challenge on the workflow front. It goes back to some of the comments I made earlier on the population health front. We need that team around to help out. I'd love to have some support that can go through the record right now and tell me which of my patients have that arrhythmia or whose blood sugars are too high. When all of this data issue started coming in, everybody talked about the Fitbit. And you'll remember all that Fitbit discussion. Let's bring Fitbit data into the EHR. And I kept pushing back and saying, well, what are you going to do with it? And how are you going to deal with it? I'd love to know which of my patients are exercising. But what am I going to do with that data? Am I going to tell somebody who's not exercising? I'm going to call them and tell them, please, start exercising. It's better for your health. I don't have time to do that. It's a primary care provider. Or if somebody is suddenly taken up running and has done a half marathon, I'd love to be able to get that patient, some kind of kudos. I'd like to be able to call them, but I have no way of doing that right now. Those are some of the challenges that we have. And that same challenge of bringing data in, whether or not it's blood sugar, blood pressure, whether it's Fitbit, all of that data, love to have it in, but how do we handle it? And who handles it? Where's that team to help out?
No, that's a great point. I mean, I think our wearables and the habits, the number of steps we've taken, I think, we have to be very careful that the EHR and the longitudinal patient record not become data rich and insight poor. Otherwise, I think there's going to be a bit of a challenge. One of the questions we get asked by our clients is, what about consumer data? What about data about habits, shopping habits, financial strength of individuals? I often would read analyses that a FICO score, for example, is very predictive of medication adherence and things of that sort. So what's your thoughts on where does the consumer data fit into thinking about the longitudinal patient view or the longitudinal patient record for that matter?
Yeah, so it's a great question. And I sort of am amused by the whole notion of getting the financial data and the consumer data. It's sort of, where does healthcare stop and Big Brother come in all of this? And then the question also becomes, what do I do to intervene? Those are the kinds of questions we ask. And, am I going to go start looking through their credit card records and finding out how often they order pizza? Is that something that I need to do and then somehow admonish them? It seems a little bit of an overreach from a healthcare point of view and from healthcare systems points of view. So people talk about this, and I'm sure that there's great data in there that says, yeah, it's a predictor. But then what are we going to do about it from a healthcare system point of view? Where's that overreach? I just feel like it just seems too overwhelming to get that data into the system. If we're struggling just to get blood sugars in, how are we going to handle financial data? I do think, though, that it's important to ask questions from a social determinants point of view if there's some kind of income insecurity that's going on, and how can we help? I think that's probably about the limit that I put in that topic.
Yeah, I think there are some definite privacy concerns that would be raised, but if you were to do it in a cohort-based way with de-identified data and aggregate, do you see a role for understanding motivations and behaviors that might help you be a better clinician and help your peers through the technology that you would implement? Perhaps offer different therapies or treatments to different groups of individuals.
And, this whole notion of like nudge science.
Mm-hmm.
How do you properly motivate a patient for a change in behavior, for an improvement in their health? What's the right way of reaching out to them? And yeah, I do think that there are ways that we could use data and analytics to approach that. I think that's wide open right now. It's interesting. There are some groups that I know that are using some kind of chat bot to help out in that process. Some people are using reminders sent through either emails or text sent to the patients. I think those are really fascinating approaches. I'm not certain that they can have the kind of ROI. I'm not sure it works for all patients, but I think that's definitely worth exploring.
Yeah, no, that's well said. So I know you and I share a passion for the next generation of health IT leaders, whether it's lecturing or collaborating with them on various projects. What advice do you have as you see your younger peers getting into the field with tools that we didn't have when we started getting into health IT? What advice do you have?
So you may laugh at the advice because, yeah, there are better tools. The EHRs have become more sophisticated, and we can do a lot more with our digital tools. I mean, when you and I started, smartphones didn't exist. You couldn't text. There are so many more things that you can do day to day. But in the process of delivering all this, we need to both streamline the way that patients can get into your healthcare system, but also create a stickiness to that healthcare system. Now, you are a primary care provider. I loved that longitudinal patient care. I loved those patients that I could see for years at a time. I miss that in the current practice that I have. I just don't get a chance to see patients. Somehow in the digital tools, we have to still enable that kind of closeness. We have to allow that kind of relationship to blossom and to remain a key component to the healthcare that we provide. You and I both can think of many instances where that kind of relationship helped you to diagnose a patient or intervene in a way that led to a better patient outcome. We have to keep that in mind. Digital tools help, but all of that has to go around the patient and the provider and how you can, in some way, enable that better relationship. And I think that's a challenge. I also think that the data and analytics, well, I don't want to say that it's easy, but sometimes in the data and analytics, you still have to go down to the workflow to try and understand what the underlying cause is. I think too often we get into the data and analytics and go, well, the issue is here. And then people kind of they brush it off and go, okay, go take care of it. Too oftentimes, I think the workflow is not taken into consideration in the process of delivering whatever it is that the data and analytics was supposed to help with. And that leaves a group with a gap in actually trying to successfully implement whatever the challenge is. So I tell our colleagues that are in this process, never forget the workflow. I mean, I remember, and you'll probably remember this, that when we were at the Cleveland Clinic, we were trying to prevent some insurance denials with the EHR. We couldn't figure out why the intervention wasn't working. And I literally went to our GI suite where they were doing endoscopies and colonoscopy, and realizing that what they were doing inside of that suite wasn't really using the EHR. They were printing something out, which we didn't anticipate, and completely bypassing the intervention. So sometimes you've got to get down to that level of observation to try and understand what the real issue that you have to solve. So I would encourage everybody to not forget that. I also think that we have to get away from legislating common sense in our EHRs. If you do that, you end up with an overly developed, overly complex EHR that is harder to build and hard to maintain. That's something that we are struggling with at Baycare. It's, as I mentioned before, we have 15 hospitals. And in many ways, each of those hospitals was built up with a slightly different design in the EHR and that affects our ability to maintain it, we have to go back to our clinical leaders and the people who are running those hospitals and get them to coordinate. That's a much more difficult process. So I tell you, as our colleagues join in our digital transformation efforts, as they get into informatics, I'd ask them to try and think about ways of standardizing across the system so that your EHR and whatever intervention you've got actually works for all the various clinical areas that you have.
That's great advice. And if I could summarize that, and tell me if I got it right, Alan, what you're saying is to make sure that we're patient-centric, that we tell our colleagues who are going into the field that at the end of the day, it's about the patient. It's about improving the way they do things. And the spinoff would be that patient will be more loyal to that health system that does a much better job with keeping them engaged. I also heard something which I see myself repeating over and over again as well, is that at the end of the day, you can build the most amazing tool, but if you don't have the change management and the workflow nailed down, it could fall on deaf ears, which I think is sage advice to give to the next generation. The last piece, in my prior life, I would use the concept of advocating for precision regulation, is to be very, very specific about where we need the health information technology to go and where we think it might be overbearing. And I have a very balanced view of it, as you do. Where do you think the next generation of health IT leaders and the way that they're being trained and mentored, and in some cases, those clinical informaticians who go through programs, they're being educated, do you think they're ready for this? Not all of them are going to have an opportunity to work with you, Alan. So are they ready for this?
Or you, frankly. So I would tell you that in our desire to use tools, ones that are digital in their approach, we forget the costs and the difficulty of implementing them. We also we forget the effect of how they impact the patients, their families, and the clinicians. As a result of that, we at times overly rely on technology when something simpler could be done. We have to encourage our emerging leaders to remember that technology is just one tool in how we can help patients and organizations to improve the kind of care that they provide. But it is just one tool. It's often a very complicated tool, and we have to think about other ways to achieve that aim.
That's fantastic. And I certainly hope you keep pushing on the next generation of health IT leaders to embody some of the comments that you made, because I think it's going to be incredibly important, especially in Tampa, where both my parents reside, and I want them to get the highest level of care in your system as well. Alan, if you could snap your fingers and fix just one problem in healthcare, what would it be?
Limiting me to one problem is going to be difficult by itself. I would tell you, though, that if I could snap my fingers, it would be payment reform. Because frankly, you can't transform healthcare without transforming the way that providers are paid. I'm a big fan of primary care. I think they need to get paid more. I think we need to think about how we change how we pay for healthcare as a key way of trying to figure out how we improve the healthcare of all of the people that we serve.
Wonderful. Well, with that note, we are at the end of our discussion. Alan, thanks so much for spending time with me and our audience on a topic and discussion that is so critical to our current healthcare system and improving it. I'm looking forward to doing it again very soon.
Sounds good, Anil.
Thanks again, Alan. And I'll now turn it back over to Steve.
Thanks, Dr. Jane. And special thanks to today's guest, Dr. Alan Weiss, Chief Medical Information Officer of Baycare Health System. And for our listeners, don't forget to check the show notes for links to resources and contact information related to today's show. And stay tuned to the Innovation Accelerator podcast for more shows covering the healthcare IT topics that you care about. For more information on this and other healthcare IT topics, please visit innovacor.com. I'm Steve Ambrose. Have a great rest of your day.
You've been listening to the Innovation Accelerator podcast, brought to you by Innovacor, the health cloud company. Don't forget to check the show notes for links to related resources and other information. And stay tuned to the Innovation Accelerator podcast for more programs about the healthcare IT topics you care about. Accelerate your transformation and build the future of health on the Innovacor Health Cloud. For more information, please visit innovacor.com.